My name is Bob Bucklew, and I work here at Case Western at the AIDS Clinical Trials Unit, and I am also a member of the AIDS Funding Collaborative. And on behalf of both Case Western, University Hospitals, and the AIDS Funding Collaborative, we really do appreciate the time that you're taking tonight. A couple announcements. First, tonight is this evening, the speaker is, we are filming this and we are recording it, so we will have this all available for those who can't be here. So I'm sure Melissa and you can contact me in a little bit of time if you think there might be a group that would really be able to get something out of tonight's conversation. Also, only the speakers will show up on film, so everybody, we do respect privacy. We will be taking questions after Professor Greenwald's presentation, and the good thing is all you need to do is project, and this microphone over here will pick up your questions, so you don't need to stand or walk to the microphone. So. A couple other things, we do have parking tickets to get you out of the parking garages for free. If you didn't get one, you could see Melissa or Lindsay after this evening. Also, during the presentation, there is a door through the back, so if you do need to leave, if you could, and then come back in, if you could do that through the back door, and that way it'll be a little less distracting for folks. In putting together tonight, I really would like to commend Melissa and Lindsay and Ebony of the AIDS Funding Collaborative, the staff there. They really do a wonderful job for Cleveland, and I think a lot of us do know the great job that they do for us and the AIDS Funding Collaborative does. So we really do appreciate their efficiency and their professionalism and their good humor. So, and the planning group of this event and the other events that are coming up this summer include the City of Cleveland, the County Health Department, the AETC, the Education Training Center, and the Ohio AIDS Coalition. And we really are working, do try to work close together as much as we can. And when we do it, it's always good results. So enough of all the announcements. I would like to welcome our guest speaker tonight, Professor Robert Greenwald. It's the last time I'm going to call him Professor. I just had to do that, though. I'm still of that mode. But just a snapshot, Robert has over 20 years of experience in the fields of public health and HIV law and policy. At Harvard Law School, where he teaches, he is a clinical professor of law, managing director of the Legal Services Center, and director of the Center for Health, Law, and Policy Innovation. Robert and his staff and students are engaged in state and national research, policy development, and advocacy on health law and policy initiatives. He was instrumental in implementing Medicaid waivers for people living with HIV in Maine and Massachusetts, the only such interventions in the country to improve access to health care for PLWHs. In addition to those responsibilities, this always amazes me, Robert is also currently serving as the director of the Treatment Access Expansion Project, co-chair of the HIV Healthcare Access Working Group, and as a member of the Presidential Advisory Council on HIV/AIDS. So why don't we give a great Cleveland welcome to Robert Greenwald.
Good evening, everybody. It's great to be here. I feel like it's my first experience of summer. I can't believe how warm it is here. It was not something I was expecting. Well, it's really a pleasure to be here tonight. I have about an hour to present. I want to give you an overview of the Affordable Care Act, talk about the opportunities it provides in terms of meeting the care and treatment needs of people living with HIV and AIDS. I want to talk a little bit about the Ryan White program and the sort of interaction between the Affordable Care Act and the Ryan White program, and then ultimately describe what I see as the sort of next steps that are most important here in Ohio. So it's a lot to cover in a relatively short amount of time, so I'm just going to jump right in. Is the sound okay? Yeah. Okay. So So again, my presentation is going to be divided into 3 parts. And first, I want to provide an overview of sort of where we are today in terms of meeting care and treatment needs, as well as where we're going through the Affordable Care Act. I want to spend a lot of time in part 2 talking about the Medicaid expansion, clearly an issue of very much importance here in Ohio. And then ultimately to talk about some of the experiences through the HIV waiver. You know, Massachusetts in many ways is a post-healthcare reform state in a pre-reform country. And I want to talk a little bit about the outcomes and what we've accomplished through that, and then potential ideas for moving us from here to there. So overview of where we are and where we're going. So I just think it's important to sort of try to level set for all to have a common understanding of where I think we are today in terms of meeting the care and treatment needs of people living with HIV and AIDS. I've been working primarily on Medicaid expansion for a long time, and particularly given that many people working in the AIDS service world are so dependent on the Ryan White program, people have been extremely negative about the Medicaid program. But I want to talk a little bit about where I see healthcare overall. So let me just say, the status quo, I think, even with this incredible Ryan White program that we have, is basically a train wreck. And let me tell you why. First of all, the way our system works in this country, we're one of the only major democracies in the world, the only really, that has an employer-based private healthcare system. The majority of adults in this country get their healthcare through their employment, 57% of adults. But it doesn't really work well for people living with HIV. Only 17% of people living with HIV and AIDS get their health care through private insurance. So in terms of group health insurance, many people don't work with living with HIV. Many work in low-wage jobs. Many work part-time or in jobs that don't provide health care. So the group health insurance system doesn't work particularly well. Then we have an individual health care system, which is individual private insurance, which is extremely expensive. Most people can't afford it. And then in fact, in most states, even if they couldn't afford it, under current rules, because of pre-existing condition preclusions, if you have HIV, you're ineligible. So in many ways, the private insurance system falls far short of meeting care and treatment needs of people living with HIV and chronic health conditions. Then we have the public healthcare systems, which are Medicaid and Medicare. They're the 2 biggest programs. In fact, they are by far, Medicaid in particular, the largest healthcare provider for people living with HIV and AIDS in the country, even with the Ryan White program. But the reality is that both of those programs are largely in the context of HIV disability care programs, not healthcare programs. So except for in Cleveland, this county here, and in some small other parts of the country, like Massachusetts, for most people in most parts of this country, in order to be eligible for Medicaid or Medicare in the context of HIV, if you're a non-senior, you have to be so sick and disabled by HIV and AIDS before you can get care and treatment that could have prevented you from being sick in the first place. So again, we have these great programs, Medicaid and Medicare, but they're largely disability care programs. So the combination of having a private healthcare system that doesn't work well and a public healthcare system that doesn't work that well is what leaves 14% of all people in Ohio uninsured, over 1.3 million people, but 31% of people living with HIV and AIDS in this state without insurance. And then we have great discretionary program, the Ryan White program, but I'll talk a little bit more about how that doesn't keep up with demand. But first, just to get a sense of it, so in terms of the nation, Ohio actually does a little bit better than the nation on average. You're somewhere in the middle of the pack in terms of rates of uninsurance. But I think it's just important to note that it's just an intractable problem that we've had in this country. We have over 50 million people in this country, one of the wealthiest countries in the world, who are uninsured. And it's also just important to know that uninsurance is sort of a vicious cycle that breeds more uninsurance. If you get one thing out of this presentation, it's there is no such thing as free care, right? They talk about uncompensated care. It's compensated. You pay for it through your tax dollars because the state contributes or the federal government contributes to pay for uncompensated care, or you pay for it if you have group or private health insurance. So it's really how it works is uninsured people go to the hospital or emergency room for free care. Hospitals have high uncompensated costs. Hospitals have to then increase what they charge to people that do have insurance, or the state or federal government has to step in. But the rates of insurance, the costs go up so high because they have to pass on the cost to you, that then employers end up dropping insurance coverage. So we have more people that are uninsured that end up in the system. So just to be really clear, this is the cycle that we have been in as a nation for decades now. And it's an intractable problem that needs to be solved. And then ultimately, again, in terms of the Ryan White program, and I get this slide's a little bit outdated, but let me promise you, in this age of this economic recession, it's not like we've done better. The Ryan White program has done really well compared to almost all other discretionary programs. It is incredible that we have created this $2.4 billion disease-specific healthcare program for people living with HIV and AIDS. But it's important to note that we've done a great job at bending the AIDS mortality curve. Treatment truly works. We are keeping people alive. But we have not done a particularly good job at bending the incidence curve. We have more and more people living with HIV as new transmissions are ongoing. And so increasingly there's a disconnect between Ryan White funding and need. And that's why I say the current system was increasingly a train wreck. And the bottom line, I think what we've learned is you can't fund the healthcare needs of an epidemic like HIV, more and more people living with HIV, through a discretionary program like the Ryan White program that is subject to annual appropriations by Congress. Even during the most generous times, we weren't keeping pace, and we're clearly not keeping pace any longer. And just to say, our failure as a nation to provide effective health care really is evident in this cascade. How many of you have seen the treatment cascade before? Good. It's really, I think, an important tool to really understanding, in many ways, how far short we're falling in terms of meeting the care and treatment needs of people living with HIV and AIDS. Of the HIV population in the United States, only 82% are diagnosed with HIV. Only 66% are linked to HIV care. 37% retained in HIV care. 32% on antiretroviral therapy, and only 25% have suppressed viral load. Suppressed viral load is the ticket here. We have the treatment available at this point to keep everybody, or most people, an overwhelming majority of people, healthy, particularly with early access to effective comprehensive health care and treatment. And we also know that not only can we stop disease progression by keeping people and getting people on meds and virally suppressed, we know that those who are virally suppressed are significantly less able to transmit the virus. That's what it will take to end this epidemic, right? Keep everybody healthy, suppress viral load, dramatically reduce transmission. But again, one of the richest nations in the world, but we are only at 25% of people living with HIV and AIDS suppressed viral load. So that's kind of where we are. Now let's talk a little bit about where we're going. Now the Affordable Care Act, it has tremendous challenges, and I will try to point out the challenges along the way. But it also offers tremendous opportunities to transform the system of healthcare, the healthcare delivery system in this country. So first, there are tremendous reforms to the private insurance system. Now, some of the big ones are in terms of reducing discriminatory practices that, again, have precluded people from HIV and AIDS largely from entering into that system. No longer, starting in 2014, can you be denied health insurance based on a pre-existing health condition, right? Eliminated, no longer allowed. Health plans can't drop people from coverage when they get sick. No lifetime limits or annual limits on coverage. This is increasingly a problem. There are many people living with HIV that have been living with HIV for such a long period of time that even though they have private health insurance, they're literally told, sorry, you've met the limit of HIV coverage in your plan, and you basically might as well be uninsured as it relates to HIV. That will be eliminated. And then young adults can now stay on their parents' health plan until 26 years old. That's millions of young adults in the United States, which, by the way, young adults have the highest percentage of uninsured rates in our country. Not surprisingly, because they work often in low-wage and part-time jobs. The Affordable Care Act also includes significant anti-discrimination provisions. You can't be denied participation in, the benefits of, or subjected to discrimination in the provision of health care under any health program or activity established under the Affordable Care Act. And for the first time ever, not only do we see a federal law that includes sexual orientation, it also includes protection around gender identity. So Huge coverage, really important for people living with HIV and AIDS. That's the great news. The bad news, and you're going to hear this as a common theme throughout the presentation, is increasingly we're seeing the federal government saying we're going to leave it up to states to enforce and monitor. So a tremendous amount of state flexibility. So the law is strong, but you just need to know that its strength really comes in the degree to which the law is applied and enforced. And that's going to be a challenge on the local level because the federal government is making it clear that it's largely going to have to be enforced on the local level. Now, those last two slides were about all insurance policies and the reform to all insurance. This one relates to what's going to be called exchanges, or now they're calling marketplaces, that are being set up in every state. How many of you have ever heard of the exchange or the marketplace? Okay, well, this is something you're going to all be really familiar with. It's kind of like the Expedia of healthcare. The plan is, this is what it's going to be. It's going to be online. It's supposed to be incredibly transparent. In order to be a plan, a health insurance plan that's sold through the exchange, you not only have to meet all the requirements, the anti-discrimination requirements, and the changes I was talking about before, there are additional requirements that you need to meet in order to be sold through the exchange. So in order to be sold in the exchange, you cannot charge a higher premium based on health status or gender. Really, really important. Currently, under regular private insurance, for some policies, women pay 80% more than men. You could imagine if they don't even write insurance policies for people with HIV, but if they did, as they will have to, you can imagine how much they would charge. Now they cannot charge a higher premium, regardless of your pre-existing health condition, chronic health condition. The plans must include essential health benefits package. I'm going to talk more about that. There are going to be outreach and patient navigation workers and a streamlined application process. And ultimately, all of these plans must contract with essential community providers to be part of their networks. Now, the final thing that's really great about these new exchange plans is that any plan sold through the exchange also has to offer subsidies to individuals between 100 and 400% of the federal poverty level. So up to $44,000 for an individual, up to $92,000 for a family of four, you will be eligible, if you don't have insurance, your family doesn't have insurance, to purchase insurance through the exchange, and on a sliding scale, through tax credits and subsidies, you will have subsidized private health insurance. 500,000 people of that 1.3 that are uninsured in Ohio will gain coverage by 2022, over time, people signing up through this exchange. 26% of the people currently on the AIDS Drug Assistance Program live with incomes between 100 and 400% of poverty level, will also be eligible for subsidized private health insurance through the exchanges. So again, big important provisions. Now, in terms of the exchanges, states get to choose whether they will run the exchange by themselves, whether they will have a partnership with the federal government, or whether the federal government will run the exchange. Now, Ohio's kind of interesting because Ohio says that the federal government is going to run their exchange and they don't want to have anything to do with it. But when you read what's actually happening, the state has said that they want to oversee the certification process for the insurance plans, the qualified health plans that are going to be sold through the exchange. So there are two basic functions really for the exchange. One is sort of monitoring those insurance plans, make sure that they comply with all the rules, all the actuarial values. There's a lot of technical terms, but it also means, again, you can't charge higher premiums, you have to offer subsidies. Ohio is saying, we're going to run that part. The other part is the sort of consumer outreach part. And that's like the navigation, outreach, the hotline, the website. The federal government's going to run that part. So right now, Ohio is saying that they are going to perform all the plan management activities. And this is really important. And in fact, it offers some great opportunities. Because Ohio is going to manage its plans, it means that it also has the ability to set the terms of which plans will be eligible for the exchange or marketplace. So in my state, Massachusetts, for example, we have what's called an active exchange. The federal government, if it runs the exchange, it will be a passive exchange. A passive exchange means anybody meets the rules is in. And what that means is it's very much almost like Medicare Part D, where you could have 50, 60, 70, 80 plans to choose from. And you can imagine how difficult that is, particularly if you have a range of different medications and chronic health conditions. How do you figure out which ones? Now, in my state, we have an active exchange. And what the state says basically is it's a competition. You have to offer the best benefits. You have to be the most transparent. You must have the best patient outreach and navigation systems in place. And then we only select the top 6 to 10 plans to be part of our exchange. That's an opportunity, for example, if the state runs its own exchange. The other thing I said that there's this idea of you have to, all plans by federal law have to include essential community providers as part of their plan networks. Now, Ryan White providers, for example, are on the list of essential community providers. One of the biggest concerns we should have about this transition is not only how are people living with HIV and AIDS going to transition from the ADAP program to the Ryan White program, but what about their providers? And what about the systems of care that we provide? Now, in terms of the providers, again, the law says that 20% of all members of the network must be essential community providers. Now, if the state runs its own exchange, it could demand a higher percentage. It could demand specifically to ensure that enough HIV providers are part of their network. So all of those kinds of things are going to be decided by your division of insurance, and it's all being set up now. How many of you know who your AIDS director is in your state? Do you know who the head of the Department of Public Health AIDS director is? Some of you. How many of you have ever met with anybody in the Department of Insurance? Okay, we have 1 or 2 here. It's got to change. You have to start talking about to people in the Department of Insurance. They are going to run this program. They are going to decide on the networks. They're going to decide whether the networks of new healthcare systems are sufficient. And if we don't talk to them about ensuring that sufficiency must include an adequate number of HIV and AIDS healthcare providers, we will not become part of those systems. So I think it's really important to pay attention to exchange development, and it's happening now. Now, in terms of the essential health benefits package, what the law says is that every plan sold through those new exchanges or marketplaces must provide this list of essential health benefits. Clearly a really great list in many ways for people living with HIV and AIDS. Preventive care, prescription drugs, mental health, substance abuse treatment, maternity, newborn care, among other benefits. Now again, common theme you'll hear through this presentation. When the president first announced the Affordable Care Act, when it was first enacted into law, one of the things the president talked about was we are finally going to have something like a national health care program in this country. And through this essential health benefits, we're going to reduce health disparities that exist based on geography. We're going to make sure that everybody has this list of essential health benefits. Slowly over time, partly because of pushback from the governors, partly because of the lawsuits, partly because of the economy, what we're hearing the president and the administration say is, well, this is the broad outline of the benefits that people need to have. You have to provide this, but the states are going to decide what it means to provide a sufficient service of these benefits. And so it's really going to vary, again, state by state. Again, something that needs to be paid attention to on the state level to try to maximize the potential that this essential benefits package is interpreted in ways that truly meet the care and treatment needs of people living with HIV and AIDS. And if you look at the benefits package as compared to the core services that Ryan White program provides, what you'll see is, in fact, the essential health benefits package is probably better and provides more core medical services than what are provided under Ryan White programs consistently. But you'll also see that some services do not exist, or it's unclear what it means. Home health care, medical nutrition therapy, hospice services, home and community-based services, case management, both medical and non-medical case management. It is unclear how the depth or breadth of services that are going to be provided through these new networks. Now, we will still have the Ryan White program in the short term, but we have to try to make sure that the essential health benefits that's through these new exchanges meets the care and treatment needs and provides more of these services. But it's only going to happen through advocacy. Now, in terms of Medicare program, there are also some great changes to the Medicare program in the Ryan White program. How many of you are familiar with the donut hole in Medicare? So you know about the donut hole, right? The donut hole is where after some payment at the beginning of services where it's a 75-25 split, you fall into this donut hole and the individual is responsible for 100% of the payments. The way it works out is really the individual has to pay about $4,500 out of the first $6 worth of prescription drug coverage to get to catastrophic coverage under the Medicare Part D program. Now, I have to say, the program is largely for elders, seniors that didn't have any prescription drug benefit. So for many seniors, it was actually quite an important step forward. I mean, it capped their benefits about $4,500. You could get to catastrophic coverage where insurance now covered 95% of your prescription drugs. As many of you know, for people living with HIV and AIDS, it was largely a disaster because what it meant was because of the way the law was written, true out-of-pocket expenses, the individual had to come up with this $4,500 worth of co-payments in order to get to that catastrophic coverage. And many young, low-income disabled people did not have that $4,500. Now, some of the changes through the Affordable Care Act. The donut hole is eliminated. Slowly over through 2020, it will be gone. So it'll be that 75-25 split until you get to catastrophic coverage. In addition, for those on brand name drugs, and now all HIV drugs are still brand name drugs, 50% discount on all brand name drugs. So now instead of about $4,500, the amount of patient obligation is down to $2,250. So the donut hole is eliminated, it's spread out over a longer period of time and less co-payment. So big changes, positive changes for the Medicare Part D program. And then Medicare also has to offer free preventive services at no cost to all beneficiaries. And that now also includes HIV screening as well as some of the benefits described there. And we're going to talk a lot more about it, but finally, I think one of the most important changes in terms of the Affordable Care Act is the Medicaid expansion. Now, just to be very clear, so the Medicaid expansion expands eligibility to Medicaid to everybody under 138% of poverty. So for the first time ever in this country, we were going to have a healthcare program for low-income people. You're 138% of the poverty or lower, you're in. Doesn't matter if you're working, not working, disabled, you're in. It's a healthcare program for low-income people. Every U.S. citizen and legal immigrant was to be eligible for the program. Nationally, that's 70% of people living with HIV who have income below 100% would be eligible for Medicaid. And in Ohio, again, 37% of people on your AIDS drug assistance program would now automatically be eligible for Medicaid. Now, the Supreme Court, surprisingly to all of us, in its decision said that because this change is so dramatic, that this Medicaid program, the Medicaid expansion, is so different than the traditional program, the federal government, the way the law was written, it said every state has to expand Medicaid, and if a state fails to expand Medicaid, the federal government can withhold all of the state's Medicaid funding, both its traditional program and the new program. And the Supreme Court said this program is so different from that program that the federal government can't withhold money from the traditional program if states refuse to do the expansion. So just to be clear in terms of the law, the Medicaid expansion is still the law of this land. It is still required of states. The problem is the federal government doesn't have a mechanism to enforce the states to do it. And if the states fail to do it, there's no enforcement because they can't threaten the traditional Medicaid program, which is why it's now optional to states. Now, sorry. Just two other provisions I want to talk about quickly. And then we're going to come back to the Medicaid expansion in much more detail. But also, and notice the word option there, Medicaid, the law also includes two other new important provisions in terms of the Medicaid program. It gives states the option to provide cost-effective coordinated care to people with chronic health conditions through Medicaid health homes, and it also provides an option for states to provide free preventive services. Now, in terms of Medicaid health homes, these are really important for people living with HIV and AIDS. Under the law, when the law was written under the Affordable Care Act, it had a list of chronic health conditions that states could choose to provide enhanced and coordinated benefits to that population. And the federal government would provide grants to help states figure out how to do it and provide extra resources to make it happen. Now, I have to say, HIV was not even on the list of chronic health conditions when the law was first written. But the law allows the Secretary of Health and Human Services to add other chronic health conditions. And within a few months of the law being enacted, there was sufficient advocacy from the HIV community that HIV is now on the list. And New York, for example, has just initiated a Medicaid health home program for people living with HIV. All 56,000 people living with HIV in New York will now be eligible for this health home program. Well, the good thing is Ohio actually has a number of different initiatives around this health home model. So you're sort of, even in this, with this, I got somewhat conservative Republican administration and legislature, you already have several health home programs going. So I think it's something to pay attention to. Particularly, you still have to do the advocacy work around the expansion to begin with, but even once the expansion happens, because if you think about it, what the services are, again, it's sort of enhanced care coordination, it's integration of behavioral health, mental health, and substance abuse services with primary care, it's increased patient engagement in care, training, it's practice transformation and workforce development. It's exactly what we've been doing through the Ryan White program for the past 20-something years. So we talked a little bit about integrating providers through the essential community provider provisions. The way to integrate the models of care, the Ryan White delivery system, into healthcare reform is through this Medicaid health home program. And as you can see, in 2010, Ohio launched a patient-centered medical health home that was largely connected to medical and nursing schools to try to really change curriculum and change practice. And then in 2012, for people with serious persistent mental illness in 5 counties to do, through the Affordable Care Act, this health home model for Medicaid. So it's something that really can happen here and would make a huge difference in terms of meeting the care and treatment needs of people living with HIV and AIDS. Now, in terms of free preventive services, I talked about the Medicaid expansion and how the Supreme Court made it optional to states. As far as I'm concerned, that's sort of once again throwing our poorest, most vulnerable people under the bus. Everything else was upheld, they're optional. Well, in terms of free preventive services, it's the same thing. All the private health insurance plans now have to provide these preventive services sold through the exchanges. Medicare has to provide these free preventive services, but it's optional for Medicaid. If states opt into it, they get enhanced federal support for doing it. But just to get a sense in terms of sexual health and disease prevention, these would be the free preventive services that people are eligible for. And then in terms of women's health, there's a huge list also of free preventive services. So this is something that the state can get even without expanding the Medicaid expansion. They have to opt into the free preventive services. And I should have said that in terms of health homes too. It's something you can do for your traditional, even if you don't opt, but again, optional to the state. So in terms of where we're going, this is sort of the summary slide. The part that is hopefully clear is that from this part of the presentation, the Affordable Care Act offers tremendous opportunities here. But all the parts in red that are underlined sort of are there to highlight how many things, particularly in terms of Medicaid, option, state option, state option. That means advocacy in order to make it happen. And then everywhere where it says federal and state regulation has really transitioned to the state's going to decide. And that's many of the core provisions. So truly, how well the Affordable Care Act works in Ohio is really up to the state of Ohio. So in terms of where we're going, tremendous, tremendous potential here. But the potential will only become a reality if we help this state to transform the system in a way that meets the care and treatment needs of people living with HIV and AIDS. Does anybody have any questions about that part before I transition to part 2? Yeah.
So you know how you was talking about like healthcare for low cost people?
Low-income people?
Yeah, low income people. What about people who are homeless living with HIV? Like say they were like on top of their
Low income means from zero, no income, up to 138% of poverty. So if you would be eligible, regardless of your housing status, if you're homeless or not homeless, you would be eligible for health care.
So like people out on the streets, like if you go downtown and you see the people out on the streets and they have some.
They wouldn't have a home still, but they would have health care, yes. If Ohio expands Medicaid, yes.
What about possible synergy between the ACA and comprehensive immigration reform? You know, there's a lot of conversation about national origin and legal, like the word there. What about the 12 million documented people that need care and many of them are HIV infected?
Great question. So I think that immigration reform, first of all, I hate to say, but over the past few weeks, all my friends in DC that I work with on this stuff are getting more and more pessimistic that they're actually going to be able to pass something. So that's the sad starter. The other thing to say is, so in this country, the way it works, if you're undocumented, illegal immigrant in this country, basically you're precluded from benefits from almost every program, not the Ryan White program. And don't think Congress doesn't know what's going on there. They know exactly what's going on, and we've been successful through advocacy to explain why it is extremely important in the context of a communicable disease, in particular, to make sure that anybody in this country has access to care and treatment. In terms of reform, when the Affordable Care Act was first being debated, the first paper that ever came out was Senator Baucus, chair of finance. He wrote a position paper, a white paper, that basically documented that the 5-year ban on immigrants is the stupidest rule that could ever exist, because these are people legally in the country, paying taxes, but we don't provide with health insurance if they don't have health insurance. So the only place they can get care is in hospitals and emergency rooms. So basically, he did a report that demonstrated that it is costing us billions of dollars. Despite that fact, and said, we are going to fix this through the Affordable Care Act. By the time it became law, the provision was eliminated. And the reason why, the change, and the reason why is there was such anti-immigrant sentiment that even the Democrats weren't willing to stand up for this provision that's costing all of us as taxpayers billions of dollars. Now, I do think clearly something has changed since the election. All of a sudden, the Republicans have this idea that, you know, let's just be very frank about this, that they're going to somehow get the Latino vote, and the way to get the Latino vote is to change immigration policy. I agree completely that there's an opportunity here, if they do an immigration reform bill, to particularly try to change the law as it relates to legal immigrants. And that is absolutely part of the discussion and debate. So the people on the federal level that I work with on healthcare work are absolutely working on that provision. Now, as it relates to undocumented immigrants, I can just tell you, even our closest friends are basically telling us to shut up. So I don't think we're going to make big progress through an immigration bill on health care for undocumented. That's just the reality. I think that's true. Now, in terms of the Ryan White program, I think that we'll be able to keep moving in terms of HIV. There's no talk that I hear of trying to add the same ban on immigrants that exists in other healthcare programs. This is going to be a long, protracted battle. There's still this mood in the country. Now, obviously, if the status changes of many of the immigrants that are here in this country to legal immigrants, then maybe there'll be a much significantly lower number of people that don't have health care in terms of their immigration status. But I think the undocumented immigrant health care status will probably remain unchanged for a long time to come. And yeah.
I have a concern in dealing with men's health issues and the Affordable Care Act. And how is the Affordable Care Act going to do a better outreach in terms of getting men into care, especially African Americans and Hispanics, into care much earlier than what we normally perceive now? Because men don't get into care we're the last ones to want to go to
Well,
Medicare.
I'm not sure if I think that the Affordable Care Act solves everything. So I think that the degree to which there are gender or cultural barriers to care as to why men don't get care, I don't know if the Affordable Care Act necessarily addresses that. What it does address is that millions and millions of men that don't have health insurance and don't have access to affordable health care will now have access to affordable health care. So we know that there's a disconnect between access and true utilization of health care. I'm not clear that the Affordable Care Act is going to do an amazing job on that, but it will solve the access problem. It's up to us in communities to try to change the other part. I'm going to move forward, and then we'll have more time for questions at the end, okay? So now in terms of the Medicaid expansion, let's see what we're talking about here. The part in gray is what Ohio currently provides, who they provide health care to through the Medicaid program. Now, what you'll notice is the overwhelming majority of it, by the way, is disabled. So even this doesn't do percentages, which I should have done. This just does income status. So the program is primarily for disabled adults, children, pregnant women. It does provide some access for low-income jobless parents and low-income working parents. Who's completely excluded are childless adults, and then low-income parents and low-income working parents and adults are a much lower percentage than the Affordable Care Act would provide. Sorry, that wasn't very clear. Basically, the orange part is the expansion, the Medicaid expansion to 138% of poverty. That would be 450,000 people in Ohio getting access to Medicaid by 2022. At least 37%, again, of HIV positive Ohioans becoming eligible for Medicaid. That's about 8,000 people. Now, the subsidized private insurance is the blue part, up to 400% of the federal poverty level. Now, the reason why I drew a line there at the 100% is the way the law was written, it was sort of a puzzle that all fit together. The plan was that people would get, that were uninsured, that were low income, would get Medicaid up to 138% of poverty, and then people between 100 and 400 would get private health insurance. The people between 100 and the 138, where that line is and above, there were people that were still eligible for Medicaid, but because they had slightly higher incomes, the idea was they could choose. If they wanted to, they could purchase subsidized private health insurance or stay in Medicaid. Now, the problem is that the way the law is written, I talked about those subsidies for private health insurance. The subsidies only exist between 100 and 400%, because the plan was that everyone under 100% was going to be on Medicaid. So in fact, if Ohio doesn't expand, the people 100 and above will get their subsidies. The people 100 and below get nothing. So the childless adults, that other part of the slide are the people that will get absolutely nothing through the Affordable Care Act. Now, I just want to talk a little bit about why the Medicaid expansion is so important. And I know that in terms of your legislature and your governor, they want to talk primarily about cost and economics. And I will talk about cost and economics. But I insist first on talking about the human element of the Medicaid expansion. So to start, just to say, when individuals don't have health insurance, they're less likely to participate in preventive care, relates to what you were talking about, and more likely to delay medical treatment. When you don't have health insurance, you delay going to a doctor, you skip prescriptions, or you take lower doses to try to have it stretch longer. Study after study shows that the bottom line is when people are uninsured, they're less likely to receive medical care, more likely to have poor health status, and more likely to die early. Having an ongoing source of health care matters. Usual source of health care have better health outcomes, fewer health disparities, lower cost. Having a usual primary care provider increases the likelihood that patients will receive appropriate care, increases the likelihood that people will be diagnosed early, have access to health care, to detect disease at an earlier and more treatable stage of health care. This may all seem obvious to you, but all of this relates to both improved health outcomes and lower cost. And again, You name the health condition. Study after study demonstrates that early intervention is both cost-effective and improves both individual and public health outcomes. So whether it's diabetes, mental health, heart attacks, HIV, it is 1/3 the cost to treat a person with HIV than it is to treat a person with AIDS. Every single new diagnosis that could have been prevented, new transmission, over $300,000 in lifetime cost. All of that potentially dramatically reduced by early intervention, something we don't have, again, in this country. Now, just to be very clear, every country has social determinants of health. Every country has health disparities. We're the only country, if you ask any other major industrialized nation, what's the percentage of people in your country that are uninsured? They won't even understand the question. There is no such thing as being uninsured in every other major industrialized country. Yet we spend more than any other country in the world, but we still have 50 million people uninsured. And I get Speaker Bonner recently about how, yes, we may have uninsurance, but we have the best healthcare system in the world. To who? We rank 39th percent in infant mortality, 43rd percent for adult female mortality, 42nd percent for adult male mortality, and 36% for life expectancy. Out of 7 industrialized countries, we are ranked last overall in quality of our healthcare system. We outranked only Canada in quality of care, tied for last in terms of access with Australia. On efficiency, equity, and providing long, healthy, and productive lives, we come last. So who's left for us to have the best healthcare system in the world? It's not true. It may be true if you are fortunate enough to have private health insurance and a lot of money, you have good health care. But as a nation, if it's not working for kids, women, and men, it's not working. So I think it's really important to have in context, and this is the stuff that people just somehow ignore or don't pay attention to. We pay more, but we have the worst health outcomes of most other industrialized nations. Now, there's also this challenge here in this state, and we've heard from some of your senators talking about this, that the Medicaid system is broken. First of all, the traditional Medicaid program is, again, a disability care program. It provides health care to the lowest income, most disabled people in this country. It is an expensive program. There is no question about it. I'm not here actually to argue the debates of the Medicaid program. I actually think it does a relatively good job for what it does. But still, the main point is this expansion is a completely different program. They probably made a mistake by calling it the Medicaid expansion. They probably should have called it something else. But as Chief Justice Roberts said, and the whole basis for the decision that the feds couldn't withhold the traditional money is that it is a completely different program than the traditional program. So the resistance to it, like we're putting more money into a broken system, it's a completely different system. Now, just to give you a sense of it, the traditional Medicaid program overwhelmingly funds long-term care and inpatient care. 70% of all funding in the Medicaid program is long-term care. You can call it expensive and you can call it inefficient, but we have a system where we don't provide any preventive health care, we don't provide any early intervention health care, we don't really provide that much to our seniors, then they end up being old and poor and in long-term care, and now we're complaining about paying for it. That's what the expense is for the Medicaid program. 70% of the Medicaid program is for long-term care. 19% inpatient care, only 5% on acute care, and only 3% on outpatient prescription drugs. But if you asked half of the members of Congress, why is the Medicaid program so expensive, they would say it's because prescription drug prices are so high, or outpatient care. That is not what is driving the Medicaid program. Now also, just in terms of who the Medicaid program covers, again, the traditional Medicaid program, if you look at it, 75% of Medicaid spending in Ohio, for example, is on elderly and disabled. Only 13% is on non-disabled adults. It is a completely different program. The Medicaid expansion, again, to go back here, is primarily about working low-income parents, childless adults. It's a completely different program. So then, in terms of transforming the Medicaid, we've had people in Ohio state things like, we'll focus on transforming Medicaid and trying to figure out what programs the legislature can provide to get more people off of public assistance and into private insurance. There's this whole thing about, we don't want people on public benefits. We want people on private insurance. And so we're going to get them jobs so that they have private insurance. But you need to understand, increasingly, private employment doesn't give you health care in this country. There's a disconnect. Employment does not always equal insurance. And in fact, 70% of people on your Medicaid program in your state are either working or have a family member that's working. They're disabled, but they're working because they have no choice. 58% of uninsured Ohioans live in a family with at least one full-time worker. 17% live in a family with at least one part-time worker. Only 25% are uninsured. The problem is there's a disconnect because jobs don't necessarily provide employment. And this is a little confusing, but what it basically shows is only 28% of employers that have 35% or more of their employees low-wage workers, $24,000 a year or less, only 28% provide health insurance to their employees. Only 30% of employers provide health insurance to part-time workers. Only 26% provide health insurance to people under 26, where the majority of workers are 35% or more are under 26. And in Ohio, 62% of businesses in this state are small businesses, and only 39% of small businesses in Ohio offer insurance. The fact is, if you are low wage, part-time, young, or work in a small business, you have a job, you could work 52 weeks a year, 40 hours a week, and you will still be eligible for Medicaid. The Medicaid expansion is not the same old program about disabled, non-working people. It is primarily about people that work but do not have health insurance. And Medicaid is a cost-effective way to provide health care to low-income people. We'll talk a little bit more about that. Now, just to also say that in terms of the business community, your Chamber of Commerce, relatively conservative entity, is in support of the Medicaid expansion and the Affordable Care Act at this point. They've changed post-election. And they now estimate that you would save $1.7 billion in Ohio businesses between 2014 to 2022 by implementing the Medicaid expansion. Now, in terms of cost, just so you're clear, the part on the left is the federal cost, the part on the right is the Ohio cost. For 2014 through 2016, the Medicaid expansion is paid for 100% by the federal government, and states can opt out at any time they want. So just get this so you understand this. Ohio could expand Medicaid starting January 1st, 2014 for 3 years, and it would not cost 1 penny. And if it didn't work for the state, you could opt out, and it would cost nothing. After 2016, the federal government pays 90%, and the state pays 10%. So this gives you a sense of how much the federal government pays versus how much the state pays. And so in terms of money, dollars, what it means is, now just focusing on costs, that the federal government between 2014 and 2020 pay $13 billion for health care in Ohio. It's only focusing on costs. It's not focusing on the savings that are associated, for example, with early intervention, with disease prevention, with stopping transmission of diseases, but also some things that the state currently pays for through Medicaid will now be eligible for a higher percentage federal matching rate. Some things like mental health and substance abuse treatment not currently covered under Medicaid will be covered through the expansion. And your state's conservative estimate is that the state will save $773 million through its Medicaid expansion. Okay? This is your state government's own numbers about how many millions of dollars it will save by doing Medicaid expansion. Just to say, if Ohio doesn't expand, on the other hand, its costs will increase. Because one of the things is the federal government pays for what's called disproportionate share hospital payments. These are the hospitals that provide that uncompensated care. As I said, part of it gets passed along to those of us who are insured, but the other part of it gets paid for by the federal government and state government. So your state pays some money and the federal government pays some money. But when the Affordable Care Act was enacted, they thought there was going to be a Medicaid expansion and there was going to be subsidized private health insurance that would provide health care to over 75% of the 1.3 million people that are uninsured in Ohio. They said, well, one of the offsets is we don't have to give as much money to our disproportionate share hospitals. So $18.1 billion will be cut from disproportionate share hospitals because people are supposed to have insurance through Medicaid and private health insurance. That's going to happen whether Ohio expands or not. So just to be very clear, this $13 billion federal dollars coming into from the federal government, part of it's this cut in federal payments. All of it, when it comes down to it, is Ohio has to make this tough choice in terms of your economy. Now finally, you can't underestimate what it means to have $13 billion coming into the state of Ohio. That $13 billion will generate economic activity, right? So basically, the hospitals get paid for providing the health care, the doctor then gets paid, the doctor goes to a restaurant, that's an economic multiplier within a community, right? They're estimating that in terms of economic activity, it will generate an additional 18 to $20 billion, 23 to 28,000 new jobs. And again, billions in earnings to the people of Ohio. So let's be clear here. The conservative Republicans in your legislature that are saying we're not going to expand because we care about jobs and the economy clearly don't understand that this is about health, jobs, and the economy. It is completely political as to why they don't want to support Obamacare, because the reason your governor and 10 other Republican governors post the election changed their position is because the governors are in the position to say, whoa, this is going to cost us a ton of money, we're going to lose jobs, we're going to lose a lot if we don't do it. And these legislators just haven't caught up yet. So be very clear, Medicaid expansion is increasingly nonpartisan. It's increasingly, particularly by governors, being assessed by its mayors. Your governor has proposed an approach to do the Medicaid expansion. We're now calling it the Arkansas model because Arkansas stole your governor's idea and they're going to run with it. I just wanted to explain it to you quickly. What your governor has proposed is basically to kind of privatize Medicaid. It's the idea of, for people 100% or higher because they're eligible for subsidized private health insurance, put them into subsidized private health insurance. For the people that are lower than that, let's buy them insurance, and that's basically the approach. Now, just to be very clear, the Centers for Medicaid and Medicare Services have reviewed these plans. What they've said is, we will allow Arkansas, because they're moving forward with this, to do this. But if you do it, you must provide a wraparound, which basically means coverage completion. You must make sure that all the same coverage is provided that would have been covered by Medicaid, and people can't have to pay anything more than what they pay through Medicaid. So you'd have to provide additional subsidies and premium assistance to people through it. I have to tell you, it's a complicated issue in many ways. I personally am in favor of it. I think that the Medicaid program probably is better at providing coordinated, comprehensive health care to low-income people. But if what's going to get your state to go forward is to provide private health insurance to your lowest income citizens, do it, I think. I don't see the downside as long as we make sure that it's truly monitored and that they truly have to comply with all of the requirements of Medicaid. It would be an incredible step forward. Just so you know, as you know, your governor is in support of Medicaid expansion at this point, not until after the election. 10 other Republican governors, not until after the election. They now know. It's the law of the land. It is moving forward. It's really going to be a tough one here. You know, it's so far your legislature hasn't been that supportive. There's an October 1st deadline for the administration to prevent terms or any kind of federal deal. Your governor's still trying to work with CMMS in Washington and figure out a deal. The deadline obviously is December 31st for this year. But just know, states can enter in at any time. If it doesn't happen in 2014, it could happen in 2015. And I just have to tell you, when Medicaid was first enacted, many states said they would never sign up for Medicaid. Ultimately, every state signed up. When the CHIP program, the Children's Health Insurance Program, was enacted, states said, we'll never step in. It took Texas 4 years. They were the last ones. Every state provides it. When Rick Perry was running for governor, he said, you know, I'm going to stop the Medicaid program in my state. 2 minutes later, never mind. The bottom line is, this is too good a deal. This is billions and billions of federal dollars. But you need to understand that the final challenge is politics. When it comes down to it, your legislators, particularly the Republicans in conservative districts, are afraid. They've put themselves into a box. They've said, they ran on, I will overturn Obamacare. And now they're concerned, if I let this happen, somebody from the Tea Party or some right will run against me and win. It's all about politics here now. All of those governors, those 10 governors, they didn't have new information after the election that they had before the election. It was they were hoping to overturn it. Once they realized the political reality, Obama won the election, the Supreme Court upheld it. It's moving forward. It's the law of the land. You can be really stubborn. But again, don't underestimate the politics, which again is why I'm saying this privatizing Medicaid plan, the Ohio model, let's call it, could be an out. Because you get to say to them, you're not doing Obamacare. We're not doing Medicaid here. We're going to privatize it. We're going to have private health insurance for low-income people. That's what the Medicaid expansion is. You got to give them an out politically. They need it. And again, it's maybe hard to swallow, but there's going to have to be something that convinces them, because they've put themselves in a box. They've staked their whole political career on the fact that they're going to overturn Obamacare. But that's not a reality. And then, where's my last? Oh, the only other thing to say, you have to remind them, if they don't expand, your tax dollars, your Ohioans' hard-earned federal tax dollars are going to go to pay for health care in Massachusetts, in Vermont, in California. It is absolutely going to be used for this. So again, and then also remind them they can opt out at any time if it turns out not to work. There's really no excuse not to do it. Now, I just want to quickly talk a little bit about how good it can be. So, I am so fortunate because I helped create it, but I also live in the People's Republic of Massachusetts. And we are definitely a post-healthcare reform state and a pre-reform country. Almost all of the provisions in the Affordable Care Act were based off of what we've accomplished in Massachusetts. We have Medicaid expansion. We have subsidized private health insurance. Let me just show you here in terms of our outcomes. Massachusetts has 80% of its HIV population retained in care, as opposed to 37% nationally. We have 72% taking medications, as opposed to 33% nationally. We have 59% with suppressed viral loads, as opposed to 25% nationally. In terms of incidence, and the statistics are a little bit outdated because of the federal government's delay in reporting, but from 2006 to 2009, our incidence went down by 25%, while the rest of the nation went up by 2%. As of the end of 2011, our incidence rate has now fallen by 44%. Our death rates also decreased by 44%, as opposed to 33% nationally. Our hospital care spending and our health care spending on HIV-positive patients has gone down. And the state estimates that we've saved $1.5 billion by delaying disease progression. People stay HIV positive, don't progress to AIDS, 1/3 the cost of treatment. Each HIV infection averted saves about $300,000. Let me just point out that just looking at the cost side, the cost part for Ohio is completely covered by the impact of the Medicaid expansion for people living with HIV. Because again, 46% reduction in incidence by getting people on meds virally suppressed. It can end this epidemic. Now, in terms of the Ryan White program, just be clear, we use every penny of our Ryan White program. Here, what you can see is how in 2005, it was still, like every other state, mainly full pay, paying for people's prescription drugs. Now, 2011, it's almost all about premiums. It's the subsidies, even for the private health insurance subsidies, they're just not deep enough. And that's probably going to be the same nationally. And we use our Ryan White money to help low-income people meet their premium and co-payment obligations. That's how it works. And Ryan White also provides essential care, such as dental and vision and behavioral health that's not covered. And then essential services like case management, transportation, and nutrition support. And let me just say, California implemented a waiver recently, similar to the waiver that you have here in, what's the name of the county? Sorry, that county. Hey, at least I know what state I'm in. I just want to say, so California implemented a waiver similar to the one you have here. This waiver was planned for a number of years. Between the federal government and state officials, they went forward with this plan thinking that people living with HIV and AIDS were going to stay on the Ryan White program. Not one person in the state government or the federal government bothered to talk to anybody that knows anything about HIV or the Ryan White program, in particular its provision of payer of last resort. That the moment the Medicaid expansion went online, people living with HIV had to transfer over to the Medicaid program. As a result of that, the benefits package had nothing to do with what people living with HIV need. There was no model of care delivery for people living with HIV and AIDS. There were no essential community providers in the plan. It was a complete disaster. People fell through the cracks. People lost continuous health care. I only point this out to say that this Affordable Care Act offers tremendous opportunities, but beware. If you don't plan well, if you do not make sure that your government is moving forward and considering the needs of people living with HIV and AIDS, we will be left out, and then we will be moving in the wrong direction. So a couple of things. You have to get involved in Affordable Care Act planning and advocacy. There is not anything ever in the history of our work on HIV that I can think of that is going to transform the care delivery system for people living with HIV as this. And I'm telling you, if you think that the person sitting to your left and right is going to do it and you're not going to do it, nobody's going to do it. And if that's what happens, it's not going to work. There are so many things happening. The timeline is short. I get that it's difficult. It's hard to think like, oh, well, how am I going to do it? I'm not me spending 20 years doing this work. But I promise you, we can give you really straightforward, simple talking points. There are people in the room that are doing this work. You have to get involved and join them. We are a small population, but we're mighty, right? I mean, we can make things happen. We made the Ryan White program happen. We can make this happen, and we can make it work for us. Now, I have to say, you also have to get involved in Ryan White planning and advocacy. We are going to really need to start documenting the ongoing importance of the Ryan White program. The program is going to change, but we need to really start thinking about and talking about what the future is for a Ryan White program when the overwhelming majority of people living with HIV and AIDS in the state are now insured. What does that look like? And I just want to say, we have some really strong arguments that it's very different, for example, to have to pay $2,000 in insurance when you earn $18,000 if you're a healthy young person than it is if you're a person with HIV and AIDS. That a person may need Ryan White support. It is not okay for us not to have transportation, case management, those other food and nutrition services. We have the arguments, but we have to be careful. If we think that we want everything, even in the Obama administration, I can't tell you how much time I spend with them saying, but isn't this just exceptionalism? And we have to say, just in some ways, HIV is exceptional. It is different. It is still potentially communicable. It is a communicable disease. It is an epidemic that is not over, and we need to keep the movement going forward with support of the Ryan White program. But again, there's a lot of work we have to do here, but it's not going to be easy. And then I just want to say to those of you that work in AIDS service organizations, it's going to be different. The world's going to be different. We have to integrate. We have to figure out ways. If you provide services, if you are 100% Ryan White funded, you're in trouble. You have to figure out ways to diversify your funding. If you provide all these essential services but not at all linked to healthcare, you have to figure out ways to integrate. If you are just a small organization that just provides one program, you better either grow or merge, because there's just not going to be enough money around over time. That is going to be the reality of it in the best circumstance. And I just have to say, if you think that you're going to just do what you're doing, rely on Ryan White, not think about these changes, half of you, 5 years from now, as AIDS service workers, will be gone. So it is a time where you must integrate, grow, or go. But pretending that this change is not happening is not going to work. It's just a reality. One last thing. You got a problem, another one here in Ohio. So the Medicaid Pharmacy and Therapeutics Committee has now proposed to add HIV drugs to the Medicaid preferred drug list. Currently, we have unrestricted access to HIV meds. Now, they're going to say, not a big deal, we're putting you on the preferred list. Don't be fooled by this. The move here, it's a continuum. You can either be on unrestricted, preferred, non-preferred, which is much worse. But there's no reason to move people from unrestricted to preferred if there isn't ultimately a plan to tier the preferred. And what the tiering means is they will decide based on which pharmaceutical companies give the best rebates or who gives what, which drug is the preferred drug and which one's not. That doesn't work in the context of HIV, as we all know. The drugs are not necessarily interchangeable. There's resistance. There are a whole range of other reasons. And just so you also know, on the non-preferred list, there are such restrictions as fail first, which basically means you have to take a less effective medication that's cheaper for at least a month or more to prove that it doesn't work before you can get the drug you need. Access to the appropriate medications is one of the most important things we need to fight for. They are not thinking clearly about what this means for people living with HIV. You have to stack that house on June 12th during that hearing. You need to contact the members of the committee. You need to contact your legislators. It's in the handout that you all got. Tyler's here, who's helping to organize a response to it, aren't you? Okay. So please, if you can, pay attention to it. I think it's really important. And here are some resources. Thank you. Yes.
If I'm reading it right, where the state makes some of the decisions in your earlier slides, sexual identity and orientation fall into the category of things the state.
No, it's mandated by federal law that under the Affordable Care Act, you cannot discriminate in any way based on sexual identity or sexual orientation. But the enforcement is going to happen on the state level. So unless you, so first of all.
Okay, so that's my question.
Yeah.
We don't live in a real friendly state. I was born in this country, but I'm basically illegal in this country because I'm gay. How do we think that the Supreme Court's decisions in June are going to affect the ability for the restricted states from making those kind of decisions in a negative way? Because most of our cases are men who have sex with men, which I don't think the state differentiates between gay and men who have sex.
So I'm sorry, are you asking how I think the marriage cases are going to impact? I'm a little confused.
Yeah, how is that going to affect
Well, I think that
long term?
the marriage
states not being
cases.
able to discriminate.
So the marriage cases what they'll potentially do, particularly for people that are in relationships but can't get married and are therefore illegal or undocumented, can change that, right? So that would be one thing that it would potentially change, so that the percentage of, because if there's no Defensive Marriage Act, then you can get married in a state that allows you to get married, and that would be recognized, and then so that would make a difference there. In terms of the law, it is truly about monitoring and enforcement. The federal government is ultimately responsible for the Affordable Care Act. So you have lawyers here, you have like ACLUs, the legal service community. You must engage them in this. They should be looking at all of the qualified health plans. They should figure out if there are ways just on the face of the policies themselves, if they discriminate in any way based on gender, sexual orientation, or sexual identity. If they do, they should demand that those provisions be removed from those policies. And if the state doesn't enforce it, they should go to the federal government. The Secretary of Health and Human Services is ultimately responsible for mandating it. So, but again, it won't happen unless somebody pays attention to it, is really the point. So it is the law, but it has to be enforced. Yes.
So following up on that point a little bit, so currently our state Medicaid program doesn't pay for services that transgender people need that are sort of transitioning. Will this require them to do that?
I think so. See, that's what's interesting. So this is the part that's going to be the fight. The federal government's saying we're going to leave a lot of flexibility for the states to design it. But we're going to have to sue that says, number one, it violates the statute, either by the federal or the state. And I think actually if we push enough, even if the state denies it, if we get it then up to the federal government for review, we can win. I think that would be a perfect example of provision that on its face violates based on gender identity.
We talked about the Affordable Care Act not addressing certain things like health-seeking behavior of men, whoever the population is. How did you get to where you got in Massachusetts? It wasn't just access.
No, so I guess I should have been clearer and said, so we are successful for a whole range of reasons. So number one, we're lucky to have had the Ryan White program, right? So we still have our Ryan White program. We have a waiver from the 75-25 rule that says 75% is to go through to core medical services, because we don't need it for core medical services. Everyone has either Medicaid or subsidized private health insurance. About 97 or 98% of our population is insured at this point. I mean, we have very low uninsurance rates in our states. So we use the Ryan White program for things like that. But I have to say the other thing that we did, and this was just a right move, it turned out, is we've always integrated with our community health centers. Our community health centers have always been at the forefront of HIV care. And so once the change happened, because the Affordable Care Act gives billions and billions of dollars to help build community health centers. I mean, where are all these 30-something million newly insured people going to get health care? The plan is the community health centers. I mean, there are a lot of concerns, by the way, about provider capacity and all that. So, but I think that, again, it's infrastructure. And so by having such a strong network of community health centers that provide HIV care, just through those networks, we've really helped to get people and retain people into care. Yes?
You mentioned that having a voice is very important at this stage of the game on the statewide level, especially in things involving ACA. How do we do that? How can someone in this room do something effective like that to be there with the decision makers?
I'm going to have Tyler answer that question.
So there is, as Robert mentioned, a small but mighty group working on this issue. And so the Ohio AIDS Coalition has been doing a lot of work to meet with legislators over the last several months, including leading back to our statewide policy day where we're trying to plant the seeds of what health reform may mean for people living with HIV. So we continuously are doing that work and trafficking people to our website. We actually had some legislative visits earlier today here in district in the visit talking with Cleveland-based legislators. And there will be plenty of opportunities for folks to continue to get involved. So I would say if you are interested in doing more legislative visits, we are actively doing them every single week, whether it's in district or in Columbus, the State House, and you can let us know, and we'd be happy to take folks along.
Where did you access your people with AIDS from Northeast Ohio to do these visits?
Today, our visits were just with Sarah and I. We did not have anyone with us because they were last minute scheduled. And we've not done any district visits here in a couple, well, it's been a while since we've done visits here in Cleveland. But we have not done in-district visits in quite a while, so we're ramping that back up.
John, are you going to be doing any of that in the community here?
I've just met with the speaker this morning. I think everybody's just sort of banging away at us, talking to everybody that we can, just trying to get it moved. But you're right, it's politics.
It is politics. And I mean, I do a lot of TA in states, and there are states that we work in a lot, and like in Texas, we sit there and we just brainstorm about, so what's the talking point? How do we move them? Again, the economics are just huge, and the reality is I think, in a kind way to say, you may win this next election because people don't get it, but by the next election, people are going to get it. When they start hearing about what's going on in every other state, and you're not doing it, and the jobs and the money pouring in, we just have to figure out things that resonate with them.
I would also say that if you don't receive updates from the Ohio AIDS Coalition, we send out on our listserv an e-policy update every other Friday. Sometimes if there's a more relative issue, it comes out as needed for folks to take action on specific issues or things that are happening in real time from the State House here. So we definitely encourage you to sign up on our listserv via ohioaidscoalition.org. The action alert that Robert talked about for the P&T committee, if you don't want to follow that really long link, you can also just go to OAC's website and click straight through.
Any other questions? Well, thank you all.